Probably all of you might have experienced this scenario many a times during routine checkup of an individual or when we plan for some procedure. Incidentally, we might get HBsAg positive report, and sometimes residents or doctors might come into contact of HBsAg positive individuals, or even they might get a prick and later they find the individual is HBsAg positive. So in all these scenarios, what should be the next line of evaluation and management we will discuss in today's video. The first thing which we have to know is whenever we get report as HBsAg positive, it is not a direct indication to start antiviral therapy. Instead, we need to evaluate systematically to distinguish between whether it is acute hepatitis B or chronic hepatitis B and how severely it is affecting liver, as well as if it is chronic, we have to look for the stages of liver disease. So all these things will matter before considering antiviral therapy. This is the first point all of us should get clarified. So now, how to evaluate this case? We have got HBsAg positive. Then we need to send for some of the serological markers like IgM and IgG antibodies for core antigen of hepatitis B, that is HBc, IgM and IgG we need to send, as well as we have to recommend for HBeAg and anti-HBe antibodies. Here to simplify, I will recommend you a simple suggestion that now overall we are discussing about hepatitis B. It will have numerous antigens. For example, the S surface antigen, C core antigen, E antigen will be there, and whenever these antigens are there, there will be development of antibodies against all these. So this is the first basic point we have to understand. So now we have got HBsAg as positive and we have sent for these serological markers. So suppose we get IgM antibodies as positive report. What that will suggest? We all know that IgM will indicate some acute infectious state. So in this case, because the surface antigen is also present in the body and there are some antibodies which are indicative of acute infection. So we have to consider this as acute hepatitis B viral infection. The second scenario might be individual has got HBsAg positive but the IgM and IgG antibodies are negative. So what might this indicate? The body has been exposed to the antigen probably, but there is no antibody response yet. So this might indicate either early phase of acute infection, or sometimes this might be falsely positive. That's why body has not generated any response. So that might be the second possibility, false positive. So how to evaluate this? If it is in the early stage of infection, we need to repeat the entire serology after 2 to 4 weeks so that we might detect the positive IgM antibodies if it is the actual infection. Suppose it is a false positive report. Nowadays, because of the good standards of immunoassays, we will not get false positive reports commonly. But suppose the individual is recently vaccinated with hepatitis B, there might be chances of false positive HBsAg. So in that case, we have to repeat the serological evaluation after 1 to 2 weeks. So in that case, what happens? This will turn negative and we can see the antibodies for surface antigen, that is anti-HBs antibodies will become positive, and of course the individual is not being exposed to the core antigen during vaccination. So even in repeat sample, the antibodies for core antigen will remain negative. But in case you are in hurry or you are totally in the suspicion of liver injury when you got HBsAg positive but the antibody is negative and you don't have time to wait for 2 to 4 weeks, you can directly send for PCR to detect hepatitis B viral DNA levels through PCR. So if it is there, it will indicate acute infection. The third scenario is you have got HBsAg positive and when you sent the antibodies for core antigen, you got IgG as positive. That will again indicate the presence of chronic infection which was not detected earlier. Coming to the importance of HBeAg, this will indicate the level of replication of the virus as well as the infectivity. So suppose the individual is HBeAg positive, that will indicate there is high viral load and high chances of infectivity. Suppose we get antibodies against this antigen, that will indicate the person is less infective and has developed a good response to the extent to suppress viral replication. So I hope you are clear about this point now. HBsAg positive plus IgM positivity will indicate acute infection. HBsAg positive plus IgG positivity will indicate chronic hepatitis B infection. The confusion comes when there is positive HBsAg but the antibodies are negative. So in that case, remember two possibilities. One might be false positivity. So in that case, we have to ask for the history of recent vaccination. Second one is very early stage of acute infection where we need to repeat the similar tests after 2 to 4 weeks. Now we will deal one by one. The first scenario where we got HBsAg positive and when we sent the antibodies for core antigen, so the anti-HBc antibodies, mainly IgM, is positive. So we consider this case as acute hepatitis B. So what to do in that case? We have to treat it as supportive therapy only. For example, advice for bed rest if the individual is facing fatigue, and high calorie, low fat meals should be advised, and discontinue any non-essential hepatotoxic medications. Also, advise them to limit paracetamol to less than 2 grams per day only, or if possible to avoid completely. And the usual symptomatic therapy should be advised, for example, antihistamines for pruritus. For more than 95% of the immunocompetent adults, this supportive therapy is more than sufficient because they will clear the acute viral infection spontaneously without requirement of any antiviral medications. But there are some scenarios where even though it is acute hepatitis, we need to initiate antiviral therapy. So what are those conditions? Suppose there is severe acute hepatitis indicated by prolonged PT-INR, or if there is development of jaundice with bilirubin value of more than 10 persisting for more than 4 weeks. So in that case, we need to initiate with antiviral therapy. So we have the option of tenofovir and entecavir. Suppose the individual has developed fulminant hepatic failure, that is hepatic encephalopathy or rapidly deteriorating liver functions. So in that case also, we need to initiate antiviral therapy immediately and if possible, refer for the workup of liver transplantation. And suppose the individual is immunocompromised or on chemotherapy, we need to start the antivirals immediately. Now, based on the severity of liver involvement, we have decided either supportive therapy or antiviral therapy. So how to follow up this case? We need to monitor LFT and PT-INR weekly to prevent any acute worsening of the liver failure. Till 6 months, we need to do this. After 6 months, if HBsAg becomes negative and there are production of antibodies to this surface antigen, then we can declare the patient as cured. So the antigen is being cleared from the body and for protection, the individual has developed antibodies. That will indicate patient is got cured. But suppose after all these things also, if HBsAg remains positive, this is an indication of transition from acute to chronic hepatitis B, which then needs again special evaluation, which we are going to discuss. So the first scenario is clear regarding acute hepatitis B. This one we have already discussed regarding the negative report. Either it will turn into acute hepatitis B or there might be false positivity due to vaccination. Now we will see, suppose the individual gets IgG positive with the incidental detection of HBsAg. We consider it as chronic hepatitis B. So in that case, what we have to do is look for the viral activity by sending the DNA quantitative analysis through PCR. This will measure the baseline viral replication levels. Also, we need to send for liver function test to monitor baseline ALT and AST. Also, we can take the help of CBC to look for low platelet count, which is an early indicator of portal hypertension or advancing cirrhosis. So these tests we can advise for if we are thinking of chronic hepatitis B. Many times, if the disease is already advanced, we might get the enzyme levels as normal. So in that case also, we can take the help of imaging. For example, ultrasound abdomen to look for coarse echo texture of the liver parenchyma or splenomegaly. Even it will screen for hepatocellular carcinoma. There are numerous non-invasive scores which we can utilize. For example, APRI. and FIB4 scoring, through which we will get to know the parenchymal changes in the liver. And if available, advice for transient elastography, which is highly effective modality for directly quantifying liver stiffness. So some of the blood parameters like LFT, CBC, and some of the imaging modalities we are utilizing to decide the next line of management in that individual. Now we can arrive at two decisions. One is the individual needs immediate treatment. The second possibility is we can defer the treatment with antivirals. So when an individual requires immediate treatment in case of chronic hepatitis B is if there is evidence of cirrhosis either clinically or by elastography. Otherwise, if there is persistently elevated ALT and if the viral load is more than 20,000, we can consider immediate initiation of the treatment. And remember one more number, that is, if the viral load is more than 2000 with HBeAg negative report, we have to initiate the antiviral therapy. And when we can consider deferring treatment with antivirals is, suppose the patient is having normal enzyme levels with the DNA levels below the cutoffs mentioned and there is no evidence of cirrhosis. So in that case, we can monitor this individual every 6 to 12 months for the worsening of liver state. Some of the mandatory screening which we need to consider whenever we get HBsAg positive and especially we think of chronic hepatitis B are always screen for co-infections like HIV, hepatitis C and hepatitis D, because these co-infections will alter the disease progression as well as the prognosis and treatment regimens. Especially if you know when there is co-infection of hepatitis B and HIV, the regimen which we commonly follow will be LET regimen. We often say whenever there are both the infections in a similar individual, we call it as let's treat both. Similarly, if the individual has any high risk of developing hepatocellular carcinoma such as family history of liver cancer, in that case we need to screen for carcinoma with alpha fetoprotein every 6 monthly. So these two are the mandatory screenings we need to consider. Along with this, whenever any individual gets the report of HBsAg positive, it is a common scenario to get panic. So from our side, the counseling part is very important. Mainly explain that this hepatitis B viral infection is manageable chronic condition as well as advice for screening in other family members. And if they turn out to be negative, then advise them for taking vaccine against hepatitis B. And for that particular individual, we need to advise with some lifestyle modifications such as avoidance of alcohol, weight management, and avoidance of over-the-counter hepatotoxic medications, including paracetamol, which they have to limit to less than 2 grams per day. So these are few things which we need to focus upon along with the management of chronic hepatitis B. And regarding this scenario, we have already discussed in the previous slides. So whenever we get incidental HBsAg positive report, but the antibodies are negative. So in that case, one of the reason might be false positivity due to recent vaccination. So the history is very important. Why this happens after vaccination is the recombinant vaccines contain purified surface antigens that can spill into the bloodstream, giving a false positive result for 14 to 18 days post vaccination. And this state, that is the positive surface antigen, will be cleared within 2 to 4 weeks by the body itself by creating antibodies against these surface antigens. So always repeat the test after 4 weeks, where we usually see the negative report of surface antigen, and if you send for antibodies against these, usually there will be presence of antibodies with no antibodies against core antigen. So this will suggest that the individual is successfully vaccinated. As a quick summary, we will go ahead with these 3 scenarios. Otherwise also, sometimes you will be getting the patient being referred with all these serological reports. So how to assess these? For example, in scenario 1, the individual has HBsAg negative and there are no antibodies against the core antigen, but antibodies are present against surface antigen. So how to interpret this? These antibodies are present because of vaccination. So body has created antibodies for the surface antigen which was there in the vaccine. but it never creates antibodies against the core antigen because it is not being exposed only. Second scenario is surface antigen will be negative, but antibodies against core antigen as well as surface antigen will be positive. So definitely we can interpret that this individual has got exposure of both the antigens. That's why body has developed antibodies against these two antigens, which will naturally happen during infections. So the virus and the antigen has got cleared, but the antibodies to surface and core antigens are present as a mechanism of defense. And suppose the individual is having negative report of all these serologies, especially when suspected some correlation of hepatitis B with the liver manifestations. These individuals, we can say, susceptible just like the other normal individuals, so we can recommend them with the standard vaccination for the future prevention of hepatitis B. Now comes another section of important discussion regarding accidental exposure to hepatitis B for a healthcare worker, which is very, very common. Most often we see due to needle stick injuries, or the healthcare workers will be doing some procedures, then they accidentally get to know that the patient is HBsAg positive. So what to do in that case? Usually most of the healthcare workers will be vaccinated with hepatitis B. In that case, they will be having the antibody titer of more than 10 most often. So we need to send for the titers. If it is more than 10, nothing to worry. They are already protected and no intervention is required. But in case if that healthcare worker is not vaccinated, or even though vaccinated, the titer comes as less than 10. So in that case, we need to advise with dual interventions. First thing, administer the immunoglobulin against hepatitis B within 24 hours as a mode of passive immunity. Along with this, we need to initiate hepatitis B vaccine simultaneously but inject at a different site. So we can follow 0, 1, 6 months. The usual schedule of hepatitis B vaccination can be advised. Finally, we can say whenever there is accident HBsAg positive report, we need to remember few of the golden rules. If there is evidence of cirrhosis by either lab parameters or by imaging modalities, it will bypass all the rules. So you have to initiate antiviral therapy in that case. And especially in advanced cirrhosis and all, we will get normal levels of liver enzymes. So do not consider it as a normal liver. Focus upon the imaging and based on that, consider initiation of the treatment. And right after the vaccination, up to 4 weeks, you might get HBsAg as positive report. So this is one of the reason for false positive accidental detection of hepatitis B. So in that case, ask the history of recent vaccination and wait for 4 weeks. Then you can repeat the test. By the time this antigen given in the vaccine will be cleared out from the body. So this was the overall discussion regarding accidental detection of HBsAg positive case. If you find it useful, please share it among your batchmates, colleagues, other doctors as well as nursing staff, because this is one of the commonest scenario which we face on daily basis in our clinical practice. Thank you so much.